thank you to Eileen and John Kim for organizing this year, and we're hoping we'll be able to do another one in person again in not too distant future, maybe back at Berkeley next year. Not sure. We'll find out. So thank you all for being here.
So we said everybody could introduce themselves. We're going. And now we've got a lot of people on this on the screen. So just give your name, your affiliation, and sort of your area of study, I think. Theresa, you can go first. This is where you're on my screen.
I'm Theresa Andrasfay. I'm a postdoc at USC in the biodemography and the gerontology group. And I'm a demographer who studies mortality, life expectancy, and physical functioning.
Margarita.
Hi, I'm Margarita Osuna. I'm a PhD candidate at University of Southern California. I work with Jennifer Alshire, and I'm also in the biodemography lab, and I work with Eileen Crimmins. And I'm interested in Latin American aging and Colombian population aging.
Okay. Rebecca.
Hi, I'm Rebecca Wong. I'm a professor at the University of Texas Medical Branch. I'm an economist and demographer, and I serve as PI of the Mexican Health and Aging Study.
Aashish.
Hi, I'm Aashish. I'm a Bell Fellow at Harvard University. I recently graduated from Penn, and I'm interested in mortality in low and middle income countries. Thanks.
Fernando.
Hi, I'm Fernando Riosmena. I'm an associate professor in the population program in the geography department at the University of Colorado Boulder. And I study the causes and consequences of migration, including on the consequences side, the aging and health of Mexicans on both sides of the border.
Hiram.
Hi everyone. I'm Hiram Beltran Sanchez, Associate Professor at the School of Public Health at UCLA. And I do work on health inequalities and biomarker data in Latin American countries mainly.
Ciao.
Hi everybody, my name is Chao. I'm a PhD candidate at USC and I work with Eileen. My research interest is population health biomarkers. I also have an interest in aging in China. Nice to meet all of you.
Jessica.
Hi, I'm an assistant professor at USC. I'm a demographer and work primarily on cross-national comparisons of US life expectancy and inequalities in health and mortality.
Joseph.
Hello, Joseph Saenz. I'm an assistant professor in gerontology at USC. My research primarily focuses on disparities in cognitive aging, particularly in Mexico.
Brian.
Hi, everybody. Brian Downer, Associate Professor at University of Texas Medical Branch in Galveston. I'm a gerontologist, and most of my research is focused on studying life course determinants of dementia and cognitive decline.
Rachel.
Hi, I'm a PhD candidate at USC, and I'm interested in inequalities in health and aging and cross-national comparisons.
Philip.
Hi, I'm a postdoc at University of Texas Medical Branch. My research is on caregiving and cognition for older Mexican and Mexican Americans.
Ron.
Hi, I'm an emeritus professor at UC Berkeley in demography and economics, and I have a long-time interest in mortality and socioeconomic differences in mortality, but my main work now is in evolutionary biodemography and the National Transfer Accounts Project on consequences of population aging.
Thanks. Yi-Chen.
Hi, everyone. I'm Yi. I'm a PhD candidate at USC Price School of Public Policy. Hard to define my discipline, but I work closely with Eileen and Julie Simopoulos on dementia prevalence, disparities, and family spillover of dementia. Nice to meet you all.
Jerry.
Hello, Jerry Behrman in economics and demography at the University of Pennsylvania.
no more needs to be said. Okay. Julia.
Hi, I'm Julia Walsh. I'm a retired professor in the School of Public Health. My interest has been long-term in healthcare in developing countries and maternal and child health particularly.
Ileana.
Hi, everyone. I'm Ileana Koller, and I'm research assistant professor in population studies at the University of Pennsylvania. My focus is on health, mortality, aging in low-income contexts, and specifically sub-Saharan Africa.
Noreen.
Hi, I'm Noreen Goldman. I teach at Princeton. My research is in the area of demography and social epidemiology, focusing on social disparities in health and role of biomarkers and stress.
Yulin.
Hi, I'm a postdoc at UCSF, and my interest is social causes and the consequences of chronic pain. I'm using HRS and share. Now I'm try to develop my interest in middle and low income countries about pain problems.
It's a very young baby. Shane.
Hello, everyone. My name's Shane. I am a postdoc at USC. I work with Eileen and Jennifer. My primary research interest is disability and functional limitation in a cross-national context.
Carl.
Carl Bowe with the Department of Demography at Berkeley and HMD.
Yuan?
Hi, my name is Yuan Zhang. I'm a postdoc at Carolina Population Center at UNC Chapel Hill. I study cardiometabolic health and cognition, especially in developing countries. I'm a gerontologist by training.
Thank you. Okay, now I switch screens. Christopher?
Hi, I'm an MD PhD student at Duke in public policy and economics. I'm interested mostly in supply side of healthcare markets in developing countries.
Mateo.
Hi, everyone. I'm a postdoc at USC, sociologist and demographer, and I work primarily with Eileen and Jennifer. And my interests are cognitive aging, life course, and thinking about aging processes in minoritized communities.
Paloma.
Hi, everyone. I'm a graduate student at the UC Berkeley Department of Demography, and I'm particularly interested in the drivers and consequences of population aging, as well as broadly interested in mortality and formal demographic modeling.
All right. Now, if anybody I didn't ask, you can step forward. My screen switched twice, and so I may have missed somebody. All right.
Can we have Jung introduce herself, and then we can give her a thanks now before we forget to thank her later?
Jung, we're out.
Hi, everyone. I'm Jung-Gi Kim, a research associate professor here at USC. And nice to see you all.
Thank you, and thank you for your help. So I think we're ready to start. We have a great crowd. Will and I believe that we have enough time to interrupt people if you want to say something or get clarity on the presentation, and we'll have a few minutes at the end of each presentation to have discussion, and then we have a bit of time at the end for overall wrap up and sort of thematic development and think about the future. So Will and I are going to split up this. I will introduce the first two papers, and will watch the chat and or hands and see if there's anybody that really wants to say something while the paper is being presented. So the first paper is going to be presented by Theresa Andrasfay. Theresa, do you want to try getting your slides up? On the impact of COVID-19 on life expectancy in the US and Brazil, disparities and dependencies. You have a number of authors, co-authors, Marcia Castro, Susie Gerzenda, Sun Kim, and Noreen Goldman, who's here, I guess. Theresa, are you ready?
Yes, all right.
Take it over.
All right, so like Eileen said, this is going to be examining the impact of COVID-19 on life expectancy. It's partly substantive and partly methodological. So let me just give a brief overview. So I'll start by reviewing a couple studies that we did on disparities and the impact of COVID-19 on 2020 life expectancy within countries. So in the US, this was focused on racial and ethnic disparities, and in Brazil, it was focused on geographic variation. And then I'll move to the second part of the talk, looking at an evaluation of these estimates and specifically asking, how did non-COVID-19 mortality change and how did this change impact our estimates? So to review, we wanted to evaluate racial and ethnic disparities in the US because we know that in pretty much every health outcome and in mortality, there's longstanding racial and ethnic disparities. And early in the pandemic, as evidence came out about race and ethnicity on tests and on deaths, that the pandemic was no exception and that Black and Latino populations really had a disproportionate burden of COVID-19 mortality. I think everyone generally agrees now that it's a combination of greater exposure through frontline work and essential jobs, as well as perhaps multi-generational and crowded residences, and also a higher rate of comorbidities that increase the risk of mortality. And then on the Brazil side, there were these long-standing regional inequities in life expectancy, poverty, and healthcare. And this is a paper we're not involved in, but it's a really nice map that shows the gradient here where the North really is disadvantaged on all these different aspects and the South is relatively more advantaged. And we wanted to see whether or not that would be reflected in COVID-19 mortality. We decided to estimate this using period life expectancy. So I think everyone here is familiar with it, that this is not cohort life expectancy, it's period. So it's really this hypothetical measure, and it would only be true if 2020 mortality conditions were fixed for the next century. And we really hope that that's not the case. But nevertheless, it's really useful for our purposes because it's a single measure. You don't have to compare each specific death rates, across several populations. I think people can kind of grasp it because it's on the scale of a human lifespan, and it facilitates these comparisons. So I want to preface what I'm about to show you with the fact that we were doing demography in real time. So there is a bit of a discrepancy between what you would need to calculate life expectancy completely, accurately, cleanly, versus what we could actually do at the time. So to refresh, what you needed for life expectancy in 2020 is the population at risk of dying. So that would be the mid-2020 population. And then the complete counts of all deaths from all causes in 2020 by age for each of the subpopulations we wanted to look at. And then here's what we actually had when we began these analyses. We had mid-2019 population estimates. One could argue that's not so different. We had pre-pandemic mortality rates by race and ethnicity in the US and by state in Brazil. And then we had provisional data on COVID-19 deaths for each of the subpopulations. Note, this is not all causes, and it's not even complete COVID-19 deaths because there's typically a lag. And then in the US, we actually started these analyses in June of 2020. So we didn't even have the full year. We were relying on projections of COVID-19 deaths. So there were several sources of potential error here. But we wanted to do this calculation. So we decided to use a method. I'm going to call it the cause added method. What we did is we treated the pre-pandemic life tables as cause deleted life tables in which COVID-19 is the cause that had been eliminated. So cause deleted life tables are a common demographic exercise in a problem set in everyone's intro demography class. And they're typically used for the hypothetical removal of a particular cause of death. Like we can imagine what would life expectancy look like in the US if we were to remove deaths from gun violence. Here we wanted to do the opposite. We had mortality in the absence of COVID-19, and we wanted to inflate that to try and get what it might look like once COVID-19 was added back in. But this requires a big assumption. And the assumption is that individuals who did not die of COVID-19 in 2020 were subject to pre-pandemic mortality conditions. So I'll leave that for now and show you the results from these studies, and then we'll return to this assumption. So for the US, this is a paper Noreen and I published last year, and it shows on the x-axis here the year from 1980 to 2020, and on the y-axis life expectancy at birth. And it shows the Latino, white, total population, and Black population. And what this graph shows is that from the 1990s, pretty much to 2010, there was a steady increase in life expectancy for all these populations, some stagnation in the 2010s, and then a steep drop in 2020 due to COVID-19. And the drop in 2020 erased, about a couple decades of progress in life expectancy for all groups, but it's really disproportionately impacting the Black and Latino populations. And then in Brazil, to remind you, we studied geographic variation. So let me try and describe this graph to you. Basically, the darker the color, the worse decline, and the darker pink it is, the greater the decline in life expectancy at age 65, and the darker the turquoise, the greater life expectancy at birth decline. And then dark blue means that the state experienced large reductions in both. So what you can see here is that there's a strong gradient where the northern states experienced the greatest drop in life expectancy in 2020, and the southern states experienced the lowest drop. And if you recall back to that map earlier that showed the social disadvantage scale by state, it really would overlay almost exactly on this graph, where states that have the most disadvantage experience the greatest drops in life expectancy. So that's it for the disparities. And now I'll move on to dependencies, or how did the impact on life expectancy depend on non-COVID-19 mortality? So let's return to that assumption, which is that individuals who did not die of COVID-19 were subject to pre-pandemic mortality conditions. This could be violated in two ways. The first is that non-COVID mortality could have increased. What this would look like is that the overall amount of excess mortality is greater than direct COVID-19 mortality. This could happen if healthcare and societal disruptions as a result of the pandemic increased other causes of death. So this could be something like hospitals can't take patients or can't adequately care for them for other causes, or individuals might be afraid to go to the hospital after a cardiac event, and that would increase heart attack mortality. The result, if this is the case, is that our cause added method would be an underestimate of the true life expectancy decline. The other way that this could be violated is that non-COVID mortality could actually decrease. And so this would look like overall excess mortality is actually less than direct COVID-19 mortality. And this would mean that not every COVID-19 death is a new death in 2020, or a death that would not have otherwise occurred. So this could happen if individuals with comorbidities die of COVID-19 rather than their underlying condition. This would be known as competing risks, or sometimes known as harvesting, where we can think of this might happen with cancer, where individuals who are immunocompromised, they may have died in 2020 from cancer had they not gotten COVID, but then they die of COVID instead. And if this is happening on a large scale, the result would be that our method overestimates the life expectancy decline. And when we were doing this for the US, we really thought that what would happen would be the case on the left. And we sort of assumed that this might be the case everywhere, just because the pandemic was such a big disruption to everything. But let's see how we did. So this is just going to present the national estimates rather than dealing with disparities anymore. So for the US, the direct life table calculation that incorporates all causes of death and just compares 2020 to 2019 calculates about a 1.56 year reduction in life expectancy. That is more than the cause added method that we did that estimated a 1.2 year reduction. So that means that we underestimated it as we expected. But what was unexpected to us, or at least to myself not being as familiar with the Brazilian context, is that in Brazil, the opposite was true. The direct reduction in life expectancy was 1.4 years, and our cause added method estimated a 1.7 year reduction. So we overshot it. And so we decided to, in ongoing work, we're looking into why this is the case, what age groups contributed to this, and what causes of death contributed to this. So let me walk you through this graph. This looks at how deaths changed from 2019 to 2020 in both countries. The x-axis here is the age groups, and the y is the percent change with 0 in the middle of the graph. The US is on top in the solid lines, and Brazil is below in the dotted lines. And what you can see for the US is that with the exception of the 0 to 4 age group, pretty much every age group experienced an increase in non-COVID mortality from 2019 to 2020. And the increase here is largest in this middle adult age group. In contrast, for Brazil, we see declines at both the young ages and at the ages above 55. And those are the ages, especially in the older years, where most deaths are concentrated. And so overall, there is a reduction in non-COVID-19 causes of death. So we decided to look into what causes are contributing to this, because this was sort of unexpected. So this is a heat map here that shows for ages 45 and above, where most of the deaths are occurring, how deaths changed from 2019 to 2020 for females and males. So the red is an increase in deaths and blue is a decrease, and the darker the color, the greater the change from 2019. So at the top, we have all-cause mortality. And for all-cause mortality for both Brazil and the US, these are pretty red, suggesting that mortality overall increased in 2020 relative to 2019. And that is going to go into that calculation of the direct life expectancy calculation that incorporates all causes. So it makes sense that we see a substantial decrease in life expectancy in both countries. But then when we look at all causes except COVID-19, this is sort of the same information from the previous graph, we can understand why we found differing findings between Brazil and the US with our cause added method. In Brazil, it's mostly light blue, suggesting that these causes decreased in 2020. Whereas in the US, the opposite is true, these causes increased. So we decided to look even further at what particular causes differed between the two countries. Looking at cancer, we see that both countries experienced a reduction in cancer mortality in 2020, but this is more pronounced in Brazil. And this makes sense because, like I mentioned, cancer is one of those causes of death that really, cancer is one of these conditions that really increases one's risk of dying from COVID, conditional on infection. And so it makes sense that the introduction of this new disease altered the risk of dying from cancer. Next, we have diabetes, and the pattern is pretty much the same for both countries. We see a lot of red here, showing that diabetes mortality increased in both countries during 2020. And this also makes sense because diabetes is one of these conditions that really requires pretty intense care and management. So any disruption to that during the pandemic could increase mortality for those with diabetes. And next we get to heart and cerebrovascular diseases, which is the leading cause of death in both of these countries. And here we see the big difference between the two. And so this is really the answer for why we saw differing patterns between Brazil and the US. In Brazil, we see that it's mostly blue, suggesting that heart and cerebrovascular disease mortality decreased in 2020. whereas in the US it increased. And because this is such a major cause of death, it has a really big impact on our life expectancy calculations. So next I'll just go through the last 3 major causes of death. Flu, pneumonia, and other respiratory diseases. For the most part, this definitely decreased in Brazil. I think it probably decreased in the US as well, except there may have been some misattribution of COVID in the early part of the year. And then external causes is another cause of death where we see a big difference between the US and Brazil. In Brazil, we see a reduction, certainly for females and then for males at many of these ages, whereas in the US, this is mostly red, suggesting an increase. In the US, there was a lot of media attention to increases in accidents and increases in overdoses during the pandemic. And so that contributes to another discrepancy between the 2 countries. And then last is unclassified, which increased for both. And again, this is probably unclassified COVID deaths. So to summarize, the comparison of the US and Brazil, it's interesting methodologically because it illustrates that it's not clear a priori if this cause-added life table approach yields an under or an overestimate of the change in life expectancy. But it's also an interesting case of looking at how the COVID pandemic impacted these 2 countries very differently. In Brazil, we saw that there were reductions in non-COVID mortality, and my Brazilian colleagues really think that this has to do with the fact that Brazil is at a point in its mortality transition where it's been experiencing long-term improvements in mortality, especially cardiovascular disease mortality. And it appears that the pandemic didn't really stop these improvements. To put this into context, Brazil has been experiencing pretty big life expectancy improvements. It increased from about 70 in 2000 to 76 in 2019. And in contrast, the US has been stagnant in life expectancy for the past 10 years. The US saw increases in non-COVID mortality. And my opinion of this is that because of where the US is in its mortality transition, the US is really maintaining its level of life expectancy, not through preventive interventions like we saw in previous decades, but through pretty high intensity interventions at the end of life that really rely on the healthcare system. So any disruption to the healthcare system threatens our ability to maintain our life expectancy at its current level. And then another big difference between the US and Brazil is that the US saw big increases in external causes of death, especially drug overdoses. And these data, we were not able to look at this when we did our initial paper on the US because these causes of death go through a lot of additional review and scrutiny by the National Center for Health Statistics. And their omission, really contributed to our underestimate. And it's possible, this is definitely partially a result of the pandemic, but the US is also undergoing, a second drug overdose epidemic. And we saw the continuation of that even during the COVID pandemic. So thank you, and I'm happy to answer any questions.
Will, do you want to ask your question in person?
Sure. Thank you. This was terrific. I don't know if you're going to go back and show more slides in a minute, or if you want to stop sharing so we can see each other during the discussion. So I'm just curious if you could tell us a little bit about what's known about death under registration in Brazil in particular. That my understanding is that there's a great deal of regional variation in under registration and the extent to which this could affect some of your comparisons, even at the aggregate level, depending on how big the under registration is and whether the pandemic might have affected under registration. We sort of worry about this in many causes of death, the cause attributions being interfered with in the US, but I just don't know what's going on in Brazil.
Yes, so that's a good question. And we've discussed that amongst our research team because we thought our first sense was that maybe there was a lag and we weren't getting the non-COVID mortality, especially like you said, for certain states. And we've by now been working on this for almost a year, and it seems that deaths have continued to trickle in, but they haven't really substantially changed. And then my Brazilian colleagues who are much more familiar with this have really argued that this was an issue in previous decades, but Brazil has done they've made a concerted effort to try and reduce under-registration of deaths. And I think the estimate now is that it's less than 2% of deaths are not reported. And this, like you said, it really could make a difference if we were looking at state-specific life expectancy, but I think at least for this purpose where we're just looking at the aggregate, it shouldn't make as much of a difference. But it's definitely, I mean, that's a good question, and we did look into it, and it doesn't seem like that is influencing these results too much.
I mean, just given the magnitudes, if this went from 2% under registration to 4% under registration, would that be enough to explain some of these large trends?
I think it would if they were systematically deaths at younger ages, because we're seeing that those deaths really have a big impact on our life expectancy calculations. If they're distributed everywhere, it might not make a big difference, but if, for example, certain causes of death at certain young ages, then I would expect it to have a big difference.
Aashish, do you want to ask your question?
Yeah, just trying to understand what the data context is, and is it possible to understand what how racial disparities in mortality in Brazil were affected by the pandemic?
So I think the main answer is that it's not really possible. Marcia was really interested in looking at this and tried to get the data, and apparently it's just not complete enough to be able to look at. But I definitely agree that there probably are racial disparities because Brazil has its strong colorist society that it probably would mirror what we saw in the US.
Jessica?
So the lack of heart disease impacts in Brazil is a really interesting finding. Do you know what the burden of chronic disease and sort of levels of comorbidities look like in Brazil for these age groups?
I do not. That's a good question. You mean in terms of how the degree of these comorbidities would impact COVID mortality?
And CVD mortality, because we saw like the US getting hit really hard. And I think part of the hypothesis there is how sick the US population is. But Brazil was able to avoid that. So I'm wondering if perhaps do they have a lighter burden there?
I am not sure. I wasn't looking so much at the levels, but more just the trends. But that's a good point. But I think the impact in Brazil is still pretty large. So I would imagine they still do have a pretty high level of comorbidities in middle and older ages.
Noreen?
Thanks.
Oh, I think Noreen just wanted to, am I allowed to
speak for her? I don't know.
Speak for you.
Sorry, I was just adding a little footnote to the previous answer, which is that it's very difficult to create death rates by race and ethnicity in Brazil, because what I'm told is that there's such a huge difference in how these are reported on death certificates and on censuses that much of it would ultimately be meaningless.
Can I ask one question?
Sure.
Yeah, I was struck a little bit by the figure that you showed when you look at the percentage change in mortality rates and you compare the US and Brazil, and you had the US on top, and these were done by age. What I was struck by is how large those declines were within one single year. For instance, if one looks, if I'm not mistaken, at the young ages below age 10 or 15, you had declines of close to 20% in death rates, which is fairly large for 1 year change. And this is a decline in mortality rates. And then later, when you show results by changes in main causes of death, mainly those causes were focused on conditions that are prevalent among adults or older adults. And yet some of the largest declines occurred in young ages. So I wonder if you had looked at causes of death that are more common among the young.
We have not. That is a good suggestion to do for the future. I think we focused on the older ages just because the majority of deaths were occurring there. But it would be interesting to look at what causes of death there were that changed for Brazil in the youngest ages. It is interesting because especially infant mortality would really depend on quality healthcare. So any disruption to that it is surprising that it didn't increase it. So we'll look at that. Thank you.
Can I ask if you could do a regional analysis dividing the country by the overall COVID level to see if you got the same patterns by cause of death for different regions of the country? That might add some insight into what's going on if you separated out the high COVID areas from the low COVID areas.
Right, we could look at whether areas that were likely had higher healthcare disruptions had worse.
Had a different pattern of some sort. Because it's such an interesting thing that you found. It seems like now there are a wealth of things to do to try to really disentangle what might be going on. Anybody else?
Ron and Fernando both have their hands raised.
Oh, sorry, I didn't see that. Ron.
So in the pandemic, there was a rash of papers and much discussion about the possibility that reduced economic activity and reduction in driving to work and these kinds of things would lead to lower mortality. And I wonder now, a year and a half later, how those ideas look and whether you see any traces of such effects in your analysis.
So at least in the US, I know there was a lot of discussion about maybe people will not get in car accidents because they're not driving. But then when the final data came out, we actually saw the opposite, that traffic fatalities increased, and the theories that with less traffic, people drove much faster and then got into more fatal accidents. So we didn't see that. And then I see in your comment, you talked about air quality. And I think that we wouldn't be able to see the impacts of that really yet. And I think it probably wasn't sustained long enough to see the benefits, because it was really only a few month period that people mostly stayed home. I know a lot of us are still working from home, but I think the general public quickly resumed their commuting. And so I don't think we saw enough reduction in air pollution to really realize any benefit yet.
Thank you.
Fernando, did you have a question?
Thank you. Very interesting results. Thank you. I was wondering when you said that you were, given that Brazil has experienced a continued decline in many causes of death, whether it would be, I don't know how to think about it, but whether there could be like a counterfactual of what would have happened without COVID. Like similar to, I guess, estimates of excess mortality, or I don't know how, but in a way that would take that trend out of the equation, right, and see whether the trade-offs, right, of basically COVID, maybe avoiding certain kinds of death, would be possible to further get to that attribution. And the other thing is, I don't know cause attribution, ICD determinations at all, but I wonder, for example, when you show that cancer, cancer is also like diabetes, right? It requires a lot of treatment and so on. But the fact that there was a decrease in cancer and an increase in diabetes made me think, is there anything that could be suggesting that, cause attribution is changing as well a little bit, that COVID has been, for example, that diabetes was attributed as a cause of death when COVID also had a part, whereas for cancer, it was more COVID that was attributed or something like that. I don't know if that makes a lot of sense, but something along those lines.
That makes sense. I'm not sure. I don't know too much about how these causes get attributed. I think both the US and Brazil, at least what's on paper, is that they're supposed to indicate the underlying cause of death. And if the person, would not have died at this moment due to their underlying condition in the absence of COVID, it was supposed to be attributed to COVID. But I take your point that we don't know what actually happened, practically speaking. And then I'm not sure I totally understood your suggestion to try to take the trend out of the heart disease mortality.
For example, had we expected to see already declines in heart disease mortality, then, looking at the levels of change between 2019 and 2020 may not necessarily suggest that it was related to COVID, people avoiding, stress at work, for example, and dying of heart attacks less, right? It was just that it was the continued trend that explains this change. So I wonder if there's a way to kind of separate those two things, right? The trend from the impact of COVID, I guess.
I think you're almost saying put the trend back in instead of taking it out. So
yeah, I guess in some way kind of compared to I guess, I don't know, like compared to prior years trends maybe, or prior years changes or something, I don't know.
So I didn't show it in this graph just for the interest of time, but we did look at previous years, and it does seem like the reduction in cardiovascular disease mortality is similar to what we saw in 2018 to 2019. Am I remembering that incorrectly, Noreen?
Oh, I think that is right. That's an interesting question. I wanted to just add a little postscript to the cancer versus diabetes question, which is, I think the difference is that cancer treatment really knocks out one's immune system. And so, the argument could be that being so severely immunocompromised makes people very subject to dying from COVID if they are infected, in contrast to diabetes.
So would that then suggest that the decline in cancer that we see is because these people were taken over by COVID, and we had otherwise seen a continuation of the trend in cancer?
Right. That was the kind of harvesting that Theresa was talking about, that people were speculating might be occurring throughout the pandemic, but the only evidence was cancer.
Let me just check.
Right. I don't think we think that cancer treatment improved in any way during the pandemic. It's more of this is a competing risk story where people who might otherwise have died of cancer died of COVID.
all right, I think we need to move on to the next paper. I think we've had a good discussion, and thank you very much, Theresa and Noreen. It's been interesting and eye-opening to see the comparison of the two countries. So I think we'll move now to India. And
we need a couple people who joined since our introductions. Do you want to just do a really quick additional?
I see Jim Cook is there. Jim Cook, do you want to say hello?
Hi everyone. How are you?
I'm
here.
All right. Jen Cook is from USC, and she runs the Gateway to Global Aging as well as La Ciudad in India. So, and who else joined? Will?
I joined. I can say
Emma.
Hi.
Okay.
Hi, Emma
Hi.
Aguilar. Hi, Associate Professor Sol Price School of Public Policy at USC. And a pleasure to see you all.
Thank you. Anybody else? All right. Let's turn to household wealth and life expectancy in India. 1990 to 2016. Aashish, can you share?
Yeah, sorry. Oh. Oops, sorry. Yeah, let me go back. Oh.
Okay. Okay.
Yeah. Oh, yeah. Can you see my screen?
Yeah, it's full screen now.
Okay, thank you. So thank you for this opportunity. This paper is about household wealth and life expectancy in India over this long and I believe important period. It would benefit from your feedback. So the main motivation, one of the main motivation is that recent research on LMIC, adult mortality disparity patterns, has challenged this theory that came out within social epidemiology, sociology, fundamental cause theory, that we see these differences across contexts and over time. So just to give a prominent example, this is a paper, it's a recent paper showing multiple countries. So, so the idea here is that in multiple countries, you don't see mortality disparities by education. It's only it's only people with a lot of education that have some mortality advantage. There is also this concern about growing inequality within India, especially in the context of economic reforms. However, an important part of inequality is whether people are alive or are alive to experience the development trajectory in a country, and these mortality inequalities are largely not quantified. So the debate within India on inequality has not benefited from these kinds of calculations. There is also an intense amount of debate on health system priorities in the context of ongoing epidemiological transition. So just to give one prominent example of this, H.V. Subramanian and co-authors wrote in the International Journal of Epidemiology this review article, Jumping the Gun, the Problematic Discourse on Socioeconomic Status. And then prominent diabetes doctors and researchers wrote back, generated a lot of comment about shielding against a future inferno. So the idea is fairly easy to grasp, right? So here's this country which has invested quite a bit on child health. And so if you move to if you start investing in adult health, and if you believe that these are cardiovascular diseases that are among the rich, then you're moving resources away from the poor to the rich, right? And so you can get worried about these sorts of health equity priorities for the health system. And then finally, as I think we all agree, improving empirical measurement of population health and mortality is a global scientific priority. So just the last presentation covered this quite well. So we need to calculate life tables. We need counts of death, which come from civil registration data and people censuses. These data form the basis of high quality databases such as Lambda or the Human Mortality Database, and are available for some countries. For the vast majority of the world, civil registration is not complete, and sometimes even censuses are not complete. So demographers have contributed to a variety of survey approaches in subsets of population. So the DHS with birth histories or sometimes sibling histories for adult and child deaths, the HRS and sister studies. So they have longitudinal panels, and you can see survival within panels, and they're sometimes even linked to national civil registration systems. HDSS sites, which are localized populations in which all demographic events are measured, and then the sample registration system in some Asian countries, which is basic. You can think of it as a nationally representative panel of HDSS sites. So in a large number of localized villages and urban blocks, they would do censuses and measure all demographic events. India has a sample registration system from the 1970s, which forms the basis for national life tables in India. And then, of course, demographers have contributed to indirect approaches using a variety of methods. There is one approach which generates quite a lot of, where there is not a lot of consensus on whether it's reliable or not, which is the question on recent deaths of usual household members. So in India's latest DHS, for which data is available, the 4th round of National Family and Health Survey. So this question was asked, did any usual member of this household die since January 2012? Interviews were conducted between 15 and 16. And then if somebody reported any if somebody died, there were follow-up questions on the sex, age, and month and year of death. This question was also implemented in earlier rounds of the NFHS in 1992 and 1998-2000. This is the question that I will use to generate these estimates. However, as I said, past work should make us quite skeptical of this approach. So for instance, Ken Hill wrote in 1991 that in practice, the household death approach has given very disappointing results for both child and adult deaths. Intimus wrote that the apparent advantage of direct questions for the study of age patterns of mortality are illusory, and he at that time was recommending using indirect approaches. I will say that there are criticisms of the indirect approaches as well, and the reliance on those approaches. This is a quote from Andrew Neumer in Nature, but again, you can think of these as poor solutions for poor countries. So what I do here is follow an approach in a paper that we developed with Nikhil Sudarshanan. So for ages 5 and above, we have dead household members from the module on recent deaths. So so we create lifelines starting from the age of the interview or until you turned 5 in the observation window until the age of death. For alive household members, these are from the household roster. So where a respondent or the household head or a key respondent from the household reports every member in the household and their age and sex. So we create lifelines starting at age of beginning of observation window or age 5. And then for children, we use a very standard demographic approach from the birth history module, and this is sort of well known to people. We estimate age-specific mortality rates for across ages. And so these are minor additional details. We use national survey weights to estimate NAX. We borrow them from the sample registration survey. In additional work, we have estimated NAX values from the survey itself, and they don't make much difference to the life expectancy estimates. These are survey estimates, so we need standard errors. So we cluster bootstrap standard errors. I will skip this in the interest of time, but this is, I guess, one way to estimate correct standard errors. So just to come to, is this approach reliable and can you use this approach? So what these graphs show are age-specific mortality rates estimated from the data that I'm going to use, the NFHS, and compares them to the sample registration system over time. So if you look at this graph from the more recent estimate, we see minor differences, but mostly they're very similar. So we have the NFHS in blue and the SRS in red. We should note here that the SRS is also a survey and should have standard errors, but the government doesn't release the underlying data and does not calculate standard errors for this survey. The usual concern about using survey approaches is that we will underestimate mortality and overestimate life expectancy. Here we see they're basically very similar, but if anything, the NFHS has lower estimates for life expectancy at birth. We see similar things in older NFHSs. I think it's worth noting that the NFHS has greater fluctuations, partly driven by age misreporting. Although I would say that the SRS may be smoothing its estimates, and we don't know the exact details of how SRS is estimating person years and whether it's smoothing mortality rates. But the bottom line is that this approach seems fairly reliable, and I think we could use it to understand determinants of mortality that the DHS measures. And so in this paper, what I do is we want to understand the relationship between household wealth and life expectancy. So we use a standard approach, create an asset index based on durable goods and assets. I exclude those assets which have direct links to health, for instance, sanitation or household solid fuel use. And so for each wealth category, I estimate its specific mortality rates for each round, for each sex, and separately for overall rural or urban samples. So, so the asset indices are round specific. And rural or urban or overall sample specific. Now there are advantages and disadvantages of any measure of socioeconomic status. So some disadvantages of using this is measured at the time of the interview, whereas deaths have happened before. So you could worry about the bidirectional relationship between wealth and mortality. So if someone dies, you could have hits on household wealth. Although it's useful for us to think if someone dies, you don't get a lot of money by selling the household mixie or the household fridge, right? I mean, it's a relative measure, so we still don't get an understanding of absolute measures of absolute differences in life expectancy. It has some advantages, I feel. It is available for all individuals, so whether they're children or they're adults. So education, for instance, is only available for adults. It's also available, or occupation. The typical concern used to be that like women in the household, people were not working, those occupational categories were not available for them. It is, as we know that this is easier to collect in low and middle income countries. It is also a marker of social status. So if you bought a car, you and your neighbors can see that you have arrived, right? And so it can be used to display social status also, and it is less sensitive to shocks than other measures like income. And so just to get to results right away. So these are disparities in life expectancy at birth for women and men. In blue, we have the latest NFHS round, and in NFHS 1 and 2. So I have combined the first and 2 rounds. They were smaller samples, but also we have this longer period for the older NFHS round. So I think what we see here are large disparities. So if you look at this NFHS 1, among the poorest octile, we see a life expectancy of 56.9 and 71 years in this period. 71 is like current, sort of like current Indian life expectancy. So these people already, the richest octile already had this about 20 years earlier. And then we see in NFHS 4 sort of improvements across octiles. So this is sort of improvements in population health, but we still see large disparities. Similar patterns for men. If anything, disparities are larger among men. And then so I am fairly agnostic between the cutoff points. So in the newer NFHS, which is a large sample, you can even do Ventiles. So this is women in blue and men in red. And so here you see even larger disparities between the top 5% and the richest 5%. So Matheson and Jondres say that India is sort of like part sub-Saharan Africa, part California, right? And so we see sub-Saharan African level life expectancies here. We don't see California levels, but if we had better data and if we did the top 1%, which is still a substantial population in India, we would probably see such large disparities. This is sort of robustness that we did 100 bootstraps. So if you did more bootstraps, your estimates will change slightly, but they won't change a whole lot. This is just some intuition to get there. These are patterns by residents. We see disparities in urban as well as rural areas. And so if you look at men in the more recent rounds, for the period 2013 to 2016, we see 61 years among the poorest quartile of men, 61 years of life expectancy in rural areas and 69 years, so an 8-year difference. And then in urban areas, an even larger difference. And then this is by region. So I mean, India is quite diverse geographically and heterogeneous. So here we see that, so if you think about, so this is the poorest quartile of women. This is the poorest quartile of women, and this is the richest quartile of women. So if you think about this region, 64, this is North India, sort of more patriarchal. And so you can see that these are the richest. These are the richest quartile of women in North India. They have a life expectancy of 69.1 years, which is lower than the poorest quartile in South India. So this is sort of the idea that North India is really that harsh for women, that life expectancy, even if you're very rich, is lower than if you're a woman in South India. This is sort of disparities across the life course. So this graph you already saw, female and male. We see disparities at age 15 and to some extent at age 60 also. So if you think about this is 57.3 years among women in the latest NFHS, in the latest NFHS among the poorest octiles, and 62 years, so about 5 years even at life expectancy at age 15. So this is the idea that these disparities are not just driven by childhood ages. We can see them at other ages also. At age 60, I think we have some concerns about measurement and some concerns about whether this is exactly the pattern. So these are sort of high among the poorest women. These are sort of higher than what we would expect based on earlier patterns. Among men, I think it's much clearer. So I think we have to think about age misreporting here, or about missing single person households in which basically the member died. So we're missing those in this household decent death of household members approach. But among men, I think this pattern is much more clearer with large disparities even at age 60. So this is just to hone in on this further. For child mortality, we see a decline in inequality. So this is at ages 0 and 5. For women, this is older NFHS and this is the newer NFHS. So over this period, we see both improvements as well as a decline in overall inequality. The concerning bit is this graph, where consider for women, for both women and men, but especially for men, we don't even see improvements over this long period. And basically patterns of inequality are very similar. This is sort of not that appreciated even within demography or India circles. And I think this pattern is visible even from the sample registration survey. So the NFHS estimates are not, it's not that we only see it in the NFHS, we see it in the SRS that overall adult mortality has not declined as fast as child mortality has declined. And here we see that it's basically very similar as it was over 15 years earlier. Some limitations of this, so just to wrap up, some limitations of this approach are that there are a bidirectional relationship between health and wealth. We also have concerns about missing single person households, particularly I think among older women. So if you're missing single person households, you could very well think that actually single person households in which the member have died. We do observe single person households themselves. So then if you're concerned about that, then these inequalities are even higher than what we have observed here. And so also we may be concerned about age misreporting. So again, it's useful to remember that age misreporting on average biases life expectancy upwards and mortality downwards. So again, these would lead to conservative estimates of inequality. And then of course, further investigation of why we observe this in India and why is India different than other places would be valuable. We don't have data on causes of death. We have some data emerging from LASI on risk factors and other determinants of health. Some contributions. So this is the first quantification over this crucial period. This is an important priority, I believe, that why is India sort of different than other places in terms of adult deaths. I want to say that this is not because of regional heterogeneity. We observe inequalities in all regions in India. There is also limited evidence of steep gradients in cardiovascular disease in India. So it's not because, it could be because of treatment disparities, but it's not that cardiovascular disease is much more prevalent among the poor than among the rich. It could be because what I've shown you, class inequalities are strongly tied to caste. And so we have done other work with Nikhil on life expectancy by social group, where you see even starker disparities. And perhaps we need to think about other causes of death. So I think in the age group 15 to 60, things like TB, accidental mortality, working conditions can be quite bad for poorer working men. Those kinds of things need further attention and investigation. I think from a policy perspective, I think we have some evidence if inequalities are so stark, and if you prioritize adult health, then I think we have some evidence that if you pay attention to adult health, you won't increase inequality in health spending. I want to say that this research does not tell us exactly what to do, except that you could prioritize adult health much more. And then also, I think this is nationally an important policy priority to think more about adult mortality and why it's not declining as fast as child mortality. We have provided some evidence on the reliability of survey approaches and this question. And also India is sort of, we're back to the fundamental cause world, at least in India. We document some extreme disadvantages for some sections of Indian society. So women in North India, men in the working ages who really have really low life expectancies. Yeah, thank you. This is it.
Thank you very much. Thanks. Ron, would you like to start the discussion?
Yeah, sure. I thought it was a great talk, very interesting and very just like first-rate research. I was interested in your exclusion of the assets from your wealth measure, assets that had direct health effects. And I wondered whether there's any way to look at what the effects of those particular assets might be, but I'm really not sure it would be possible because they're probably so highly correlated with the other assets that are included. Anyway, that was my question.
Yeah, thanks. No, thanks for this question. So there is quite a bit of work on sanitation and its links to mortality. Both community sanitation and so you can think of, so for instance, Dean Spears has done work on this in the Indian context. We're trying to do some work on solid fuel use. Again, you can think of direct impacts of solid fuel use on the person who's cooking, but you can also think of indirect effects. And so, I mean, this is I agree with Professor Lee that this is an important research priority, and some of it is happening.
Thank you.
Thank you. Other comments? Will, is that a hand?
Yeah, so could you please tell us again, and I know you were telling us earlier and it went by quickly, just the sampling plan for these surveys, and you talked about being worried about the single person households being missed, but do we worry about other households that of older adults that are not co-resident with the usual DHS type of sampling? And I wasn't clear whether the intention was to sample all households regardless of the age distribution.
Yeah, thanks for this question. Yes, so so in the DHS, villages or urban blocks are first randomly sampled from the census list. And then enumerators make a listing of all households in a village or an urban block, and then randomly sample. So it could very well happen that you did not have a woman in the reproductive ages, but you would still get the household questionnaire from which we get this death question. this death of recent members. And then if you had a woman in the 15 to 49 age group, then you would get the birth history, right? So and then we did some comparisons. I can show slides, but we did some comparisons of the distribution of households in the DHS versus the census. It's very similar. So what we're worried about is not that some sort of households are missing. What we're worried about is this one case where there was a single person household and in which the member is dead. So basically there's no one to report the death of that household member. These households tend to be poorer women in rural areas. So that's, I think, the population that we're really missing when you're doing these sorts of estimates.
I was curious about how your thoughts on assessing the COVID-related mortality, given the current Indian environment, and especially now you have looked at various data set, right? DHS and National Family Health Survey, which has a different sort of limitations, and as it oversamples mainly the childbearing age women and their families.
Yeah, no, this is a great question. And I think for countries like India, we will have to use whatever is available for us, right? So these include, so the latest Indian DHS, for which data is not available, had 2 waves. The first wave was pre-COVID. The second wave was between the first phase of the DHS in some states were pre-COVID in 2019. The second phase was between wave 1 of COVID-19 and wave 2 of COVID-19. It was between January 2021 to March or April 2021. So I think if we use that, perhaps we could get some understanding of 2020 mortality in India, because it also has this question. There is some partly because of brave journalists, there is some data that came out from civil registration systems, and so which shows high mortality, which is the basis of some estimates that have been published. And third, I think we do need surveys to estimate mortality. So surveys like LASI or the IHDS, when they follow up, we'll get some estimates of mortality, right?
Thank you. Ron wanted to ask a question about the first slide you put up, which came out of this meeting for, I believe, 4 years ago. That paper, an outcome of a group effort from this meeting.
Yeah. So I was interested in the slide, which you only had up for a couple of seconds, but it looked like a comparison of mortality differentials in other developing countries. I think we saw China briefly. I think that was by education. So yes. I'm just interested in partly in how your results compare to those for other developing countries. I know I know Costa Rica in some work had perhaps even reverse differentials. And I'm also interested in the usual work which is done by educational attainment, perhaps of head or individual, to your measures by wealth and how you think about those differences. But could we see that slide again? Keep that up while you're talking, maybe.
Okay. Sorry. No, thanks. I think there are people much more qualified in this room who can talk about this. I will say that India, I think, will not have education adult mortality estimates for a bit until the next round of LASI and so basically the DHS does not ask the education of the dead member who has died. Yeah. So we would need to wait until data is available to make a comparison to this graph. And sorry, you were saying something.
Oh well, just I guess these are probably are they all upper middle income countries and substantially wealthier than India?
Yeah, I think.
Or am I
so.
wrong
I think,
in that?
I think you're right. Yeah, go ahead.
So is your study one of the first, maybe the only one for lower income countries?
I think Hiram has some estimates. I'm not sure of the answer, but and then maybe there are estimates for Malawi, but I'm not sure of the answer, and I can get back to you. Again, there are people who know this.
Yeah. Okay. Anyway, very interesting work again. Thank you.
Yeah, I think for this level of disaggregation, yeah, probably what Aashish has is one of the most recent one, and perhaps very well done in terms of net worth or wealth in this particular case. So what I was also struck by, Aashish, in some of your results, when you look at the results by life expectancy at birth, I saw a very steep gradient between the poorest and the wealthiest in the early 90s, and sort of not such a steep when we get into the 2013-14. What that should suggest is that the gap perhaps has been narrowing down between the poorest and wealthiest over time, but also the steepness of the curve, meaning in the 90s, it was really steep from the bottom to the top. However, when one looks at the same value, but at age 60, there is no such a large difference between the two, between 90s and 2000s, and the steepness is fairly similar. So I think that sort of goes back a little bit to what Ron was suggesting in how you might approach causes of death, even though you don't have them. But the fact that we see such a different pattern from age 0, which I think is driven a lot by infant and child mortality, because from the age pattern that you showed has really high mortality. However, when one looks at age 60, now the impact is really older age mortality, and we haven't seen much movement in those mortality rates, at least based on the changes in life expectancy. So there must be different causes of death sort of affecting the two. So wealth, or in your particular case, will have quite a different impact in younger child mortality as opposed to, say, older adult mortality. So I think that that would be perhaps quite interesting to continue that line of work, splitting the ages that you've done, but also try to see if you somehow could split your indicator of wealth to try to pinpoint a little bit more the causes of that could be underlying those differences.
Okay. Excellent.
Thanks.
Any other comments? Because I think it's time to move on. Will, do you want to take over here?
Sure. Thank you, Eileen. So we're going to keep going. We're not going to take a break. We're doing okay on time because we built in a little bit of cushion at the end. So the two remaining speakers will get their full half an hour. So the next speaker is Fernando Riosmena, who is going to speak on immigrant adaptation and the impacts of Mexico-U.S. migration and healthy aging, a binational examination. And I'm curious to see whether you've been able to add the mortality results yet, or if this is focused primarily on the chronic disease, which is super important as well. So you have a number of co-authors on this, some of whom are in the room. So I see Jenna Nobles and Jackie Torres are co-authors, not here, but Hiram Beltran Sanchez and Emma Aguila are co-authors that are here with us. So please go ahead, Fernando.
Thank you, Will. Can people see my screen as well? Yeah. Okay. Great, thank you for having me, especially, because this is the part where we're talking about, I guess, kind of determinants of mortality. We have not been able to add the mortality results. Hiram and I are actually meeting on Monday to discuss this, among other things, but especially this, how to further incorporate mortality. But, and yes, this is in collaboration with many folks, many of whom are you in the room, besides Emma and Jenna and Jackie and Hiram. Rebecca is also collaborating in the project. Brian Downer is also collaborating in the project in different parts of this project. Trent Davidson is also in the call. He's a GRA for the project this semester as well. So thank you all for your insights. But I needed a whole slide for your names, in addition to the fact that what I'm about to present, errors remain mine, of course. So this is a little bit different from studying middle-income countries directly, but it's of course related to populations that span from middle-income countries and understanding the impact of migration international migration, although at some point we've discussed potential ways in which to include the possibility of thinking about doing something with internal migration as well, right? But it's particularly relevant from disparities perspective, which is related a little bit to Aashish, I guess, talk, for example, and a little bit of what Rebecca was showing with regards to disparities by region, and certainly what she was showing with regards to race ethnicity, race ethnic disparities in the US, right? With regards to a continued need to understand the mechanisms producing this mixed bag, mixed bag of Hispanic health. Sorry for the typo, in which we have very unexpected health indicators and certainly mortality, including old age mortality for Hispanics. Well, we'll see with the pandemic, right? That's the issue, but that's also motivation for continuing this topic. But in some outcomes, especially in cardiovascular disease, some kinds of cancer, and risk factors like hypertension and smoking and so on, for example, but earlier and faster deterioration in other kinds of health conditions, including certainly very much including not only diabetes, but another kinds of cardiometabolic related conditions, but also disability, and to some extent depression as well, or mental health, which is what I'm gonna focus on today as a example of the types of things we're doing, which include also disability, eventually, hopefully, cognitive decline, as well as certainly mortality, right? So disability and mortality as well. And this is particularly important given not only this mixed bag, trying to understand those mechanisms, but so looking at several outcomes, we think is a possible way to do this in an interesting way, or a potential avenue towards exploring some indirect way, but a compelling way to explore some mechanisms. But this is also relevant from the point of view, for example, of the Hispanic health paradox and its potential waning impacts, right? So the paradox being this, especially mortality advantage I mentioned before, and not only related to COVID, which Rebecca already mentioned, right? The Hispanic population being particularly affected by COVID, for example, along with the African-American population, and other reports suggesting the same for Native Americans. But also by the fact that there's a rapid aging of the undocumented population in the country, that there's a backsliding of immigrant social inclusion over the course of this century, that we're exploring a different part of this grant. This is an NIA-funded project. And that all of this, by the way, all of these changes might also have possible impacts on the Mexican side due to older adults' connection with the United States, especially through their migrant children, not exclusively, but that's one of the ways, an important way that we're exploring today, right? But also there's all methodological challenges to study these issues that many of you are aware of course, with regards to attrition more generally with longitudinal data, or other kinds of examination, right, of left-hand censoring and so on, as well, that in the case of Mexican migrants, for example, it might also relate especially to return-related selection, and how that can be a problem to attributing the impacts of migration. Same for immigration-related selection, right? It's a different kind of problem, but even though they're both selections, but they create different kinds of problems, and certainly they require different kinds of adjustments. They're not exactly the same or parallel to each other, but nevertheless, they produce a potential problem in attributing how much we attribute to the impacts of migration, right? Whether migration has been favorable or unfavorable for somebody, and then how does that say, or what does that say about, for example, the process of adapting to U.S. society in this case, right? So that's also related to the third challenge, methodological challenge, which is related to what kind of counterfactuals we can construct, right? And data or approaches that only use data collected on the destination side, in the US side, have potential problems with attrition related to return selection, even if they might be able to indirectly or more, in one way or another, deal with immigration-related selection in some ways. And certainly would, comparing destination or immigrants to destination area populations is very useful and very appropriate for some things, but for others, you do want to have a kind of factual of ascending area populations as well. So the objective of our project is to do this binational examination to deal with some of these methodological issues in order to understand, better understand the impacts of migration, or try to get at that, right? So we don't have so far a very sophisticated analytical strategy to try to deal with causal per se impacts, but we are trying to approach, right, to get to that by at least dealing with some unobserved heterogeneity of different kinds that would otherwise be unobserved. I guess we're trying to observe it in some fashion, measure it in some fashion, as well as dealing with some artifacts that might also create a problem with interpreting these estimates as causal. But we have also a way to go in terms of continuing in that path of attribution. But we're getting somewhere, I think. This again, I'm going to present results for depressive symptoms today, but we have disability, some results for disability. I just didn't have them as neatly presented, especially for our binational sample. So, but I can speak to them a little bit. We have some initial, discussions about mortality and cognitive functioning, given that there's more concerns about comparability of information, especially for cognitive functioning across the country, so across the two data sets as well. Related to which data sets, we're using the health and retirement study, merged with the MHAS samples until 2015. We are also going to update this analysis to include the 2018 MHAS, and I guess at this pace, at the pace we're going, the 2024 MHAS, or the not only the 2021. But but we're also starting to examine also some mechanisms, right? So not only trying to examine this general shorthand, reduced form sort of estimate of what the differences may be, and how do we think whether we can attribute them to the impacts of migration in which way, or not, but also trying to figure out how what kind of processes or mechanisms might be explaining those disparities, therefore creating a little bit more of a epidemiological pathway, I guess, in some ways, or socio-economic epidemiological pathway, I guess, more explicitly. Well, especially social, I suppose, not epidemiological per se, actually. But this includes a little bit of the examining the role of social support of protection, which is particularly important for outcomes in which there's an immigrant advantage, but where there's a disadvantage, that disadvantage could have been worse than that observed had it not been, for example, due to social support in theory. So we're examining that. We do a very initial examination of legal status, but Emma and I are examining ways to better impute legal status in the HRS in a way that would allow us to understand that. And then Trent, Emma, and I have been doing a lot of work that I'm not presenting today on trying to understand the role of the accumulation of disadvantages throughout the life course, but I can speak to that a little bit towards the end of the talk. Anyway, so the issue that I mentioned before is that there are all of these different kinds of problems, right, or issues. There are different mechanisms, right, that could be affecting healthy aging in immigrant populations in particular, perhaps, and these artifacts are important. Data artifacts, we sort of are discarding them in the sense that we don't think that there's a ton of differential measurement error, although I'll come back to that a little bit perhaps, because there are some important differences in both depression and disability between the HRS and the MHAS that might be concerning, although the more I look at them, the less concerned I am about them being data artifacts, but we have to do a little more work on that. There's, again, the issues of attrition that we try to deal with in this paper, at least in this project, at least with regards to return migration in some way. And this is just an initial examination, but we'll also, Iram and I are going to discuss potential ways to adjust for or think about mortality attrition for the outcomes, the other outcomes we're studying. And then immigration selection is also an issue. So we have a way to, we have devised a way that is similar to what other people have devised in the past in terms of trying to understand or look at pre-migration health, right, as a way to get at selection a little bit. So I'll explain that in a moment. And then those real true changes in the impacts of the immigration experience could be related to stress exposures, right, accumulated over time. So we have a procedure that we're, again, examining with regards to trying to speak to this weathering hypothesis, for example, and cumulative disadvantage, as it's known in social gerontology, that I'm not going to present today, but we are also looking at this favorable coping through social support and healthcare access by controlling for variables that try to get at that. Sorry, my phone is, I left it on. Let me just making too much noise, perhaps. And then finally, again, as a side issue, there might be indirect impacts. So this is to try to understand and get at the direct impacts of migration on the people that engage in the migration. But in addition to that, we are also going to compare people with links to the United States, with children in the United States, and those without children in the United States in Mexico, in order to try to get at these indirect impacts of migration. So the idea a little bit is...
It's a quick time check, Fernando. It's about 10 minutes left for the presentation. Thanks.
Okay, I'll get to results pretty soon, but the idea is to get, kind of understand the trajectories of people, right, and compare them across these groups based on, after controlling for selection. So let's get at that, right? So this is our basic approach, in which we're using data from both the MHAS and HRS, including in some initial kind of analysis, trying to deal with return selection by joining or trying to reconstruct the original immigration cohort for basically joining, kind of comparing, using return migrants in Mexico with foreign-born migrants in the United States, foreign-born Mexican migrants in the United States to sort of reconstruct that cohort in some fashion, right? So these are the data we're using. These are the groups. I'm not going to present data on return migrants, but I'll show you what we're doing. And this initial estimate of legal status is based on the notion that people that arrived before the Immigration Reform and Control Act was passed were subject or were able, especially those arriving before 1982, were clearly able to legalize, right, through IRCA. And reports are that very, very, very few people might have not done that. Or, of course, some people returned to Mexico before legalizing or without legalizing. But for those who remain in the United States until today, people that arrived before IRCA are most likely almost assuredly documented. People that arrive after IRCA are much less so. So we're trying to make those comparisons as well. Anyway, we're using CESD as our main measure, and it has 7 items that are comparable across the 2 samples that have similar questions in terms of the time frame of the question, as well as the items and the translation of the items and the options, the yes/no option. Some version of the scale has been validated both in the United States with Mexican immigrants in particular, as well as with MHAS participants in Mexico City in the past. They seem to have pretty good reliability overall and relatively similar reliability. So we're not fully concerned about data artifacts in that sense, at least for CESD. Similar, I think, with people that have done work with disability to some extent, but I'm happy to hear comments on that if people have any. So the basic approach we're doing right now, we're going to look at trajectories at some point. Right now, we have looked at trajectories, and I can explain that later, but what I'm going to present today are simple average differences across surveys in which the standard errors are clustered at the individual level to take into account that, of course, that time or that dependence in the data. And we're looking at these disparities across different groups by looking at while controlling for different things. So this is without controlling for anything relative to non-Hispanic whites as the referent in both cases, right? This is a combined sample. We see that all Mexican origin populations have higher likelihood of CESD than non-Hispanic whites in the United States, but I'm going to focus more on differences between these groups actually, and the confidence intervals will help us, of course, as well. we see that the US-based populations tend to have lower likelihood of reporting depressive symptoms than those in Mexico. This is particularly true, by the way, for people with connections to the United States, right? So this is what we call are suggestive of those indirect impacts of migration on those left behind, right? And there's a whole literature, of course, on that that is of relevance. And then for Mexican immigrants in the gray, we have a higher, lower symptoms than for people in Mexico in general, right? And similar to those of Mexican Americans in the United States. So once we start controlling for things, this just adds some sociodemographic controls, but I want to get to this childhood. We use childhood health as basically a measure of pre-migration, right, health conditions. So basically, after you adjust for some things like gender and age and other things, already, but you add these childhood conditions, right? You reduce some of these differences to some extent, especially relative to non-Hispanic whites, but less so for the comparisons between Mexican immigrants and those and folks in Mexico, right? So just going back, that reduction is similar across. So selection doesn't quite explain a lot of this. It explains only 10 to 16% of differences between immigrants and non-migrants, depending, and the range is because of different groups that are being compared. Either groups in the US, like US non-Hispanic whites and Mexican Americans, or in Mexico, right? So this is all comparing immigrants. And social support does nothing to these questions, and I can elaborate on that later, but I do want to get to a couple of them. Socioeconomic status does a lot, but I'll also get to that at the end. And the adjustment for attrition, for return-related attrition here, does seem to make a big difference to reduce a lot of this disadvantage that we see for Mexican immigrants because of return migrants. Now, this requires some assumptions about the reconstruction of the cohort, where basically the evolution of depression symptoms has taken place, but it's suggestive that some of this is related to return-related attrition as well, right? So it's an artifact partially, but not exclusively, especially related to Mexican-based populations. And just to also to say that legal status doesn't seem to make a huge difference with regards to, for example, a model in which we include sociodemographic controls, and this is one in which we're controlling for everything else, including some prior chronic health conditions, and in which legal people that clearly have legal status and people that don't have legal status seem to have very, very similar outcomes, even though these confidence intervals are pretty wide, but the difference in levels are remarkably similar. So just to recap, I know I said quite a bit and try to connect a lot of moving parts, so which is, I guess, par for the course for all kinds of different issues that everyone studies, of course, but certainly for immigrant health. But the take-home points are that despite the fact that there seems to be a disadvantage for Mexican immigrants in terms of the depressive symptoms, it seems like at least if you buy the idea that controlling for things that are pre-migration health conditions in childhood especially, but even like socioeconomic status to some extent, that occurs later in life, and that would be over-controlling in my view in some ways, that sort of suggests that the migration experience net of selection impacts tends to be advantageous relative to people left behind in Mexico, right? Not so much relative to people left behind in the United States. Now that's for depressive symptoms. For disability, we find the opposite, basically, in which there is a clear disadvantage with US-based populations, but a clear advantage with Mexico-based populations. So we're trying to kind of thread those two together, look at mortality as well, again, as I mentioned, and look at better ways to examine legal status. With regards to the very strong difference in impact with socioeconomic status, what we find, again, we're trying to disentangle that because, education, as many of you that study the effect of education on health know, it's not only those benefits conferred by having more knowledge necessarily only, but all kinds of advantages that are reduced by this and you know, reverberate across the life course. So we are trying to actually measure the different kinds of instances of injuries that people report in the HRS, following a little bit of the work of Bowen and Homer, for example, trying to understand and deconstruct that impact a little bit better. And I'll stop at that and see, I think there's already one question. Thank you very much.
Thank you, Fernando. That was terrific. You powered through that and leaving us time for discussion. Really appreciate it. So let me open up the floor to folks with questions, comments.
I see one from Will. Sorry, from Will. Yeah, sorry, Will.
So while we're waiting for other people, I was just curious, just in terms of the translation of the CESD instrument. So in HRS, you have some folks that I imagine who did the survey in English and some in Spanish, and I was wondering if either in HRS you see differences, or whether we know anything from sort of other work about just that translation right there. And we also know that just in many people in Spanish will use different terms for some of these issues, some of these items that are in the depression scale. So I'm curious to what extent that could affect your sort of crude differences between the HRS and MHAS results.
Yeah, that's a good question. So half of the Latino sample in HRS answered the HRS in English, right? So it's not a small number. And the CESD scale has been validated in both Spanish and English, and it seems to be equally reliable in that sense. But that doesn't quite answer your question directly, which is whether we found differences by language, and I don't know the answer to that. I'll double check. Thanks for the suggestion. I should have checked this already, of course. My apologies, but what I can say is that I did check item by item, right? So saying, all right, so what is driving these differences between HRS and MHAS? Is it one item that is dominating? And it doesn't seem to be. They seem to be pretty consistent overall between each other, each other in terms of like the levels within a survey relative to the other, and therefore the differences between them. But yeah, I'll double check, and this particularly for Mexican immigrants, but I'll double check with the language. I assume that if they were giving an option, the vast majority of Mexican immigrants would have answered in Spanish, but I will double check that.
So I think that's an interesting comment. It would be great if you had some people who would take the same scale in English and Spanish themselves. But I think people often argue that the HRS questions aren't that good because they have this response option that's yes or no. But in fact, if you're going to be comparing the two surveys, just having yes and no may be better than having a more nuanced set of response options that might be more likely to be differential in a language. So it's the first time I've thought it was a plus to have that really narrow scale in HRS.
And the wording, I mean, looking at the questions, the translation seems relatively straightforward on them, but yeah, there could be some differences there that I need to double check.
Do you know anything about personality differences between across the two surveys? Because it's not just health that may make you decide to become an immigrant or not become an immigrant. There may be certain personality characteristics that then could also be related to the likelihood of depression in the long run.
I don't. I mean,
there's a little bit on.
I mean,
there's a little bit on the MHAS that we can compare with the HRS, which is conscientiousness personality items. So that could be a possibility.
And maybe mastery or some of those ones that indicate self-confidence and ability to control one's life. So, I mean, that may be related to immigration.
Right. It may be self-selected, right?
Yeah, immigrants do tend to have, we did some basic comparison, which I think I presented at Berkeley a couple of years ago, on locus of control types of questions, and immigrants did tend to score better. The question, I guess, and you know these literatures better than I do, whether you can assume those are fixed or those have been, modified by the migration. But
they were fixed up to about 20 years ago, and then they decided they weren't. So you can find literature going both ways.
Okay. Well, but either way, they could mediate. Yeah.
So, Teresa, do you want to say your question?
Sure. So I may have missed it, but I was curious if you're able to distinguish between those in Mexico who have all their children who left for the US or some nearby, and whether the negative impacts are lessened for those who still have at least one adult child nearby.
We have not. That's a great suggestion. Jenna and Lifia are working on that part as well. With regards to, this one it's basically if the person has at least one child in the United States, we see those differences already. But, if you look at people that have all of their children in the United States, probably, you might see some gradient there. That would be nice to show. Thank you.
Okay, terrific. This is fascinating research. I'm really looking forward to seeing as you continue to get these results and these further outcomes. So I think given the timing, let's switch to our last presentation. Margarita Osuna from USC, and then I have listed your co-author as Jennifer Elsher, who I don't think is here with us today, and so you'll be talking on regional variation in mortality in Colombia. So please go ahead and share screen.
Can you see my screen?
Yeah, so we can see all of the slides queued up on the left. So I don't know if there you go, that's perfect.
All right. Okay, well, oh wait, let me move this. Okay. Thank you so much for having me here. I will present on some of the preliminary work of my dissertation chapter. And basically, I'm looking at state variation in mortality in Colombia. And I'm also looking forward to your comments and your feedbacks on what I present today. I think they're going to be very useful. So to start, I thought it would be good to start by acknowledging that there is a lot of variation within or across states in Colombia. Colombia states have very different social, economic, and health resources. And there are states in Colombia that have been historically marginalized and so have less access to economic and income. And so what this has brought, especially on a macro level, is that poorer states tend to have lower access to healthcare and lower access to education and less economic opportunities. And some studies have started to suggest that it is possible that these states that have lower access to these things also have worse health behaviors among individuals. And so we know by studies in other high-income countries that where a person lives can structure, the length of the life or the quality of their life, the accessibility to health services. It can affect, especially in Colombia, disease transmission and ecological transmission of diseases. And it can affect health behaviors or increase smoking and drinking. And this directly affects mortality differences across states. And so we were interested in seeing if state variation existed in Colombia, how it may vary in mortality. And when I started working on this project, I was a little bit surprised to see how little attention it had been brought in the country, the state differences in Colombia, especially when you look at literature in other high-income countries like the US, where state differences and state comparisons are really large, and people are very interested in them. So that was kind of a shock to me personally. To start, I'm just going to give one example. This has nothing to do with the research I'm doing, but I think it brings home the point of the differences that you might find in Colombia. So here was work done by Silvana Zapata, which is a researcher in Colombia. When COVID-19 started, she was interested in seeing the shortest distances by municipality, which are like small towns in Colombia, from an ICU. And basically, like immediately you can see here in this map that there is a big chunk of Colombia that's all green, then a part that's orange, and then a part that's red. And basically, if you see red, it means that the distance to a near ICU is really large. And if it's green, it means that the distance to an ICU is shorter. And essentially what you see here is that all these states here are cities and are more populated and so have a closer distance to an ICU, where states like that are here, such as the Amazon, has a lot of jungle and population is very dispersed. And so accessing an ICU for this case was harder. And so within these differences and like thinking about state differences in Colombia, we were interested in understanding more or less four things. So the first one was, how does state poverty vary in Colombia? The second one was, how much mortality in Colombia varies across states? And is this variability largely explained by poverty differences across states? And that also kind of brought another question we had, which was, is gender inequality variability across states? Does it exist? And can it be explained by income inequality? Okay, so to give some context, I made this, I guess you can call it a figure, where I plotted life expectancy at birth and life expectancy at age 60 for different countries in South and Central America. And I think it's important to highlight that the highest life expectancy found both at birth and at age 60 was in Costa Rica, which is well known to have very high life expectancy. And then you can quickly see that Colombia's life expectancy is also high, and it's high compared to its peer countries. It's on the 4th place, and it continues to be high regardless if you look at life expectancy at birth or life expectancy at age 60. So with that said, I would like to talk a little bit of the data I'm using. So I took in account for the population data, the 2018 national census from Colombia, which was the most recently done census in the country. And just to give some context here, the census was done first electronically. So this was like an innovation from the National Statistics Institute of Colombia, where they did first a try on electronic census, and then they did the field operation with the intent, I suppose, to try to get to more rural areas where it was quite difficult to do the field operation census. And they reported an undercount estimated at 8.5% of the population. And I will get to this in the next slide. I'll get right back to this point. The other data that I used was the mortality data. So because the census was done and was calculated by the National Institute of Statistics as to be a mid-year population of 2018, we used the mortality data, the 2018 vital statistics. And again, just to give some background on it, death certificates are usually provided by a doctor in Colombia, and they have like these series of things where if there's not a doctor, then a nurse has to fill up the death certificate, and if there's no nurse, then like a professional nurse, and so on. And when we were looking at the data for mortality data, we realized that there was also death under registration. And so we know there's death under registration, but we are not sure how it is variable by state. And so kind of to control these issues of underreporting, we did two things. So for the vital statistics, we realized that there were some states where there were clear signs of under-registration. For example, there were no deaths observed for women at ages 25 and 30 for some states. And we know that it is highly unlikely that 0 deaths occurred for a woman in these age ranges, since this would suggest 0 maternal mortality. And this is the peak of fertile ages. And we know this will not happen in Colombia, and very rarely happens in any other country in the world. And for the census, we had to drop all the states that had a range undercount between 10.5% and 28.9%. This is obviously something that we need to do some future corrections of this work in order to use some of these states, because we don't want to drop states, but for now, this is kind of what we have. So in Colombia, there's 33 states, and we dropped a total of 14 states, which left us with 19 states. And according to our estimations, we retained 78% of the estimated total population after controlling for these things. So in this map, I have plotted poverty rates that were done by the National Institute of Statistics in Colombia. And basically, I'll start by the easy part. All the states that you see in gray are states that we had to drop due to the issues, the data issues that I talked about or that I mentioned previously. And I aggregated the states, or I color-coded them rather, by poverty rates. And so we have low poverty rate, which is states that were less population, lives in poverty, medium poverty rates, and then high poverty rates. And the first thing you can notice is that these states up north almost are all high poverty rate. And then when you get to the central part of Colombia, you can see that the poverty rate decreases. And I have just highlighted here for you 3 states. One is Bogota, which is the capital city of Colombia, and you see this one is ranged as a medium poverty rate. The other one here is Antioquia, which is very well known because it has a city called Medellin, which is famous, and I think Netflix just made it more famous recently. And then here there's the state of Bolívar, which is very well known because it has Cartagena, which is a big tourist city. And they're kind of 3 different colors, right? High poverty rate, low poverty rate, and medium poverty rate. And here I also provided the average life expectancy. And so I think one of the first things that you'll notice is that the average life expectancy is very similar for low poverty rate and medium poverty rate, and it is somewhat lower for higher poverty rates. Okay. So the first step we took was to look at state variation in mortality for women. And what you see here is mortality per 100,000 for 3 different age groups: ages 20 to 39, ages 40 to 69, and ages 70. And what I did was I tertiled the mortality rates by age and by sex. And light orange is a low mortality rate, purple is a medium mortality rate, and green is a high mortality rate. And I'm going to focus on 3 different states very quickly. So the first one is Arauca, which is this green state that you see here. I picked Arauca because it had a high mortality for ages 20 to 39 and ages 40 to 69, but then you see it reduces. And just to give some background, Arauca, for example, is the largest producer of cacao in Colombia and has a lot of agriculture. The second state that I wanted to highlight for you is Antioquia, which was the state that has the capital city of Medellin. Antioquia has a lot of agriculture, but also a lot of tourism. And you see it starts with a low mortality rate for women, and then as ages increases, so does the mortality rate. And lastly, I wanted to highlight here Bolívar, which is where Cartagena is, also very touristy, and there's a lot of agriculture here as well. And you can see it starts at a low mortality rate, it increases the mortality rate, and then it goes back lower. Okay, and I think the one last thing I would say is that we can see there's some variation in mortality in ages 20 to 39, but when I saw this, I thought there was going to be more variation across the states. So just keep in mind that. I'll come back to it in the conclusions. And here is the same 3 maps with the same 3 age groups, but showing state variation in mortality for men. And I wanted to highlight, just similarly, you can see here the state that I just talked about at the beginning has a high mortality rate for men across these two age groups, 20 to 39 and 40 to 69, and then it decreases for older ages. Bolivar, which is again where Cartagena was, has a medium mortality rate, and then it decreases at age 70. And finally, Antioquia, which is where Medellin is, has a really high mortality rate for younger ages, and then it decreases for older ages. And you probably didn't notice, and I didn't bring it up, but this little part here is Bogota. And one of the things we found more interesting is that across all ages for men, you see that these states, Bogota and the states surrounding it, maintain pretty similarly. There's not a lot of variation. And so we observed that for male mortality rates, there were not a lot of variation in mortality. And so trying to understand why this was the situation and trying to go deeper into how mortality might vary by state in Colombia, we wanted to go back to our two last research questions, which were, how does mortality vary across state? And is there a relationship between mortality and poverty? And also, is there a relationship between mortality and inequality? And so this is important, and we thought that looking at mortality and its relationship with poverty and inequality was important, especially since studies have highlighted that higher levels of spatial inequality can affect society. So it can restrict development and economic growth. It can increase problems of crime and violence, and there can be less social cohesion and difficulties accessing the health system. And so we calculated age-specific female and mortality rates across the three same large age groups that I showed before. And additionally, we calculated male to female mortality rate ratios, where basically in our numerator was the mortality rate for males, and on our denominator was the mortality rate for females. So when we looked at poverty, the proportion of poverty of each state, and the death rate for men and women, we realized that we couldn't, or there wasn't any association between poverty and mortality. So let me go with you through these graphs quickly. On our y-axis, there's the death rate per 1,000 people. On the x-axis is the proportion of poverty. And then in orange, we have women, and in purple, we have men. And here I have added some information on correlations, and we ran a regression using the proportion of poverty in each state to predict the mortality, the death rate per 1,000 people, to investigate if there was a strong association or a strong relationship between both variables. And what we found was, for all of the age groups, there wasn't a strong relationship, and there was somewhat of a correlation, but it wasn't really strong. And there were, for men especially, some positive associations and then negative associations with proportion of poverty. And when we saw this and we were brought to this puzzle, we thought maybe looking at another measure of poverty could be better and maybe show a different story. And so we decided to look at the relationship between income inequality and gender inequality. So basically what we did here is we plotted the mortality rate ratio male to female. So these graphs show male disadvantage, and the Gini coefficient, which in this case was measuring income inequality. And we looked at it in the same three age ranges that we were talking about before, like a younger group of adults, the middle-aged adulthood, and then older adults. And again, we saw that there wasn't a very strong correlation. However, there seemed to be a clearer relationship between the inequality and the mortality rate ratio for males to females. And we also ran a similar regression where we didn't find any strong relationships. So some conclusions. So, although research has shown that mortality does not vary by state, and there's also a part that we're missing here, which I think is really important, and it is the within state variation, because although you can look across states the differences, the reality is that each state may have greater variation. And so we're definitely interested in looking at that. We found, as I mentioned before with the graphs, that there was no relationship between state level poverty and female mortality. And similarly, there wasn't any relationship with male mortality. And we did see that at younger ages, higher levels of state level income inequality could be associated with higher male mortality compared to women. But I think we need to do a little bit more work on it, maybe looking at more disaggregated ages or more looking at within the states to see how that affects male mortality. Okay, so one of the things I was thinking about a lot this week was I think part of our problem was that poverty is prevalent across Colombia. And so trying to compare by poverty is kind of hard because it is a low to middle income country. And if there's something that's common across most of the states is that there's a lot of poverty. So I think I'm interested in doing research taking into account further things such as education or economic opportunities and looking into causes of death, because I believe that can bring a different picture and it can give more understanding on how state variabilities might exist, how mortality variability might exist between states or across states. And definitely we need to do something about these data quality issues. I need to work on that and see how I can, correct for the undercount. But we think, just to finally close, we think that this is important research that needs to be done. Colombia is a very heterogeneous country, and it is important to understand how the states vary for us as Colombians, but also for health policy and for policymakers in the country. Thank you so much.
Thank you, Margarita. That was perfect. Perfect timing. This is fascinating work. And I see Jennifer has joined us as well. So welcome. So let's open up the floor to some comments, questions.
Okay, I didn't want to go first, but I guess I could. So very interesting work, Margarita. Thank you. It's very good that you're taking on doing this mortality analysis at that level of disaggregation in Colombia. I have some thoughts and some comments in general on what you're doing. First, I think because you're looking at the link between mortality and poverty, I see the usefulness in some ways of dropping up some states because you are sort of concerned with the undercounts. The problem is that the states that you are dropping out are states that are particularly good for picking up on variation in poverty. For instance, you eliminated states on the West. And there are two states that I'm particularly worried about, the Chocó and Valle del Cauca, because those are regions that are typical Afro-Colombian populations. And the Afro-Colombian population has traditionally had very high levels of mortality on the one hand and very high levels of poverty. The second region that you also excluded is the Amazon. So again, it's a region that has traditionally been fairly poor. So, I mean, you are downplaying in some ways the impact of poverty by excluding these places. So that's one thing that I would suggest whenever possible to try to include them, even if you might think there is some level of undercount, it would allow you to get a sense of how much impact you could have at those levels. The second possibility, you want to go a little bit deeper, is to correct the mortality. You have the advantage of having a census in 2018. So when one wants to correct mortality rates using traditional demographic techniques, the difficulty is always having a census. The moment we don't have a census, we start going, into modeling and things like that. But you do have a census in 2018. Prior to 2018, we only had the one in 2005. So in the work that I did with Alberto Paloni, we had to do a lot of tricks and things to correct the data, because that was the only anchor point we have 2005, but you do have a 2018, so that would allow you to do a little bit more. So I think that would be some possibility. And the last one, I think looking at mortality ratios is a good idea. I think it's quite useful. I would suggest to look at the work that Eileen, Doc, and I did some years ago. I think you could do way more with mortality ratios. The way you present them is interesting, but I feel it's a little bit underutilized. It's fairly simple indicator, but it's actually quite useful, as you can see in some of the work that I did with Eileen. So I think I would suggest, if possible, see if you can do a little bit more with that mortality ratios. And the final point I would make is this connection between mortality and poverty income indicators has a long tradition in demography, going way back to Sam's work in the 70s. So I think there is a lot of things that you could exploit also along the lines of connecting mortality with income, or in this case, poverty. You are using only mortality rates, but you could use additional indicators, summary indicators, as Sam did it with life expectancy, which you could also construct given the data that you have. So I think, again, it's very interesting work. There's a lot of things you could also get out of this. And the final, I guess I said final, but there is one more, which is your modeling is fairly simple. So I think given the variation that you have, it might allow you to do a little bit more modeling in terms of the variation across the states, and to add more, covariates in it. So, but great work.
Thank you, Hiram. Yeah, when I first presented this to Eileen, the first thing she told me was, you should look to that paper that Hiram, Doc, and I wrote. And I looked at it, and it's great. And I think definitely in the future, it's something I want to do in the very near future. And for what you mentioned on Chocó y Valle del Cauca, absolutely agree. It hurt me when I had to drop them, because I also agree with you of the Afro-Colombians that live there. So I do want to bring them back and see if there's a way to correct for the undercount, or try to learn what to do in order to have those states included.
Great. Rebecca, did you want to ask a question?
Sure. Thank you, Margarita. That was very good work. I was wondering if why the interest in doing analysis by state. Is there enough variation across states, for example, in the anti-poverty programs, or the way they deal with poverty, or the way they deal with healthcare, so that there's variation in mortality? And so when you compare, well, at the beginning of your talk, when you talk about the United States and the tradition of doing analysis by state, well, it's because the United States has a lot of variation by state, according to how they deal with healthcare and poverty and so on. And so the question, that's the basic question. I don't know enough about anti-poverty programs in Colombia and whether it varies by state.
Yeah, I think that's a great question. So when I was working in Colombia with the pension program, we were looking at some of the anti-poverty programs they had there, and we did see that some of the states would provide either less money to the population that was there, or would provide like different things. So maybe they wouldn't provide money, but oh my God, how do you say it in English? A mercado, like a grocery bag filled with groceries instead of money. And I think what most economists in the country have been focused on is that each state varies widely economically, and so what the cost of living in one state can differ dramatically from the cost of living in another state. And so there has been a lot of discussion around that, but not, as you mentioned, on the poverty programs. And yes, the healthcare point that you brought up is definitely something that came to mind in the past couple of weeks, and we really want to go in and see if there's healthcare access variation across the states that might also explain this.
Thank you.
No, thank you, Rebecca.
Great. Well, we're waiting for others. I'll just jump in. I point you to some work that we were able to do in Costa Rica, looking at regional variation in mortality. And one of the things that we did was just look at the longitudinal changes and sort of regional fixed effects type models. And we found very different patterns when we're looking at changes over time as compared to just the cross-sectional relationships. So I think that's a useful way of thinking about what some of the time invariant confounders are that you can control for in those models. We were also able to do some things with individual mortality studies, surveys, data that allowed us to get at more individual level measures of relative deprivation, and very different results again than using these sort of aggregate measures. But you don't have those data right now, but it just may help you think about some of the different underlying patterns.
Yes, thank you so much. I really appreciate it.
Yeah, Jerry.
Thank you, Margarita. Very interesting. I don't know that much about the Colombian anti-poverty programs, but in many countries, such programs are dominated in the same, how do I want to say this? They're dominated in nominal terms to be the same across space. But at the same time, certainly in a country like Colombia, there's lots of heterogeneity in prices across states. So you might want to think about if you can obtain information on the price variation across states. The real values of the program probably vary a fair amount across states.
Yeah, that's a really good point. I'm going to look into that. Thank you.
Good. Well, I think we should probably wrap up. I want to thank you, Margarita. That was excellent. I want to thank all of the presenters and everyone for participating. And we do have a few minutes that we left on the schedule for sort of open discussion about sort of promising areas for future research. If we really want to continue to push forward this literature and understanding the sort of patterns and drivers of mortality in low and middle income countries, especially exploiting the newer data assets that we have from mortality that we're able to measure in longitudinal sort of individual level sort of household surveys. And I'm curious to hear how people are thinking about this in the context of COVID as well. I mean, there's certainly a lot that we can learn by studying COVID, but what are going to be the impacts of COVID on our understanding of these larger patterns and trends? What kind of work do we need to do to understand harvesting, et cetera, in order to interpret the next waves of mortality data that we're getting post-COVID? So those are some of the things that I'm thinking about. But Eileen, I don't know if you have large questions that you want to put on the table as well.
Well, I'm still thinking that the socioeconomic differentials and their change over time is really what is so interesting policy-wise. And I was impressed that India seemed to actually compress the differential, except perhaps for the lowest poor men, who's ever in that category. But I thought that was fairly remarkable change. And I would like to see if we can now move to looking at some more of that in other countries. I mean, that seems to me to be important policy implications for having made that much change in the differential. And whether that's due to changing cause of death and changing age at death, that's what would be interesting, I think.
If I may, I also like the avenue that you opened with your comment, Eileen, a little while ago. I think we could potentially, with our longitudinal studies, start to talk about whether mental health or physical health or personality issues are more important for mortality.
Well, I think that is a very important avenue. So I've been working on, not working, but in a couple of meetings with Terry Moffat And she has made pleas in a couple of talks about how mental health, particularly at middle ages, is so important in the long-term health outcomes and long-term mortality, that I do think while we've sort of begun to integrate mental health into demographic studies, it's been a long time coming and we may not have fully incorporated it. I know that when we sort of try to differentiate individual level risk factors and a variety of outcomes, I'm surprised at how much really is psychological issues appear to explain long-term outcomes. So I think you're right. As the whole sets of people interested in sort of mortality and health in these countries might really be well served with a kind of network like your HCAP network that actually talks about these issues across studies and both methods and measurement and substance. It might be worthwhile. Because this is a very useful meeting, I think. Short, but we got a lot out of it. We and what's going on in a variety of places. So maybe we can do more to organize people.
Yeah,
Well,
I think
maybe
it will be.
Are you going to have a
great.
meeting next year?
What kind of meeting? This one?
This one.
Oh, yeah, I think so. I mean, it's easy enough. We could have more than one. But as Will said, I think it's our 6th year. It's been a while, and they've all been different. And we've been alternating one place or another. It was supposed to be in LA this year. It's supposed to be in Berkeley next year.
So maybe you could make a call more directed towards the topics that we just discussed and saying, well, this topic will be preferred.
I think it would be terrific, Arlene and Rebecca, if people can, like the psychologists can work a little bit more on the measurement issues of mental health. I know that for the HCAP, a lot of psychologists working on creating latent variables of cognition and really looking at the differences and trying to create a comparable measures of that. CSD or the mental health also has that issue of different scales. And I think in order to move forward, that sort of measurement issue has to be settled a little bit more seriously.
Yeah, I think that is true. And MHAS and HRS may be good for comparison, but many other studies may not be nearly as good. So I think it's a good point, Jen Cook, and it's something that your group could certainly integrate with us too to do that. I think your gateway group.
Yeah, I'd love to think about, we could put together a meeting earlier, just focused on that and bringing in some more folks with psychological expertise.
Yeah.
I think I have probably a selfish interest in that, because when Margarita and I were looking at psychological well-being in Colombia, like everyone's super happy. I don't know if it's the same in Costa Rica as like Pura Vida, and like life is so hard and they're all not depressed. They seem to be in perfectly great shape. And I don't know if it's real or if the instruments, they haven't really been validated super well in Latin American populations. So, and I've talked to like Joseph Saenz a little bit about how to like apply some kind of psychometrics to get any kind of confidence in those scales. So we've been staying away from mental health because we're a little confounded by what's going on.
Well, we have very high depression in Mexico, but very high life satisfaction too. And so again, like you said, we question whether it's a scale or it's just this culture of, it's pura vida, or it's like, it is what it is, which is the philosophy of Mexicans. Is why are you wishing for something that you can't have?
Yeah, these are hard questions.
But I think they're real questions. I mean, I really think there are great differences in how people view the world across countries, and that may have implications for a variety of health outcomes.
Yep.
Yeah.
we're never sort of reluctant to take up a new field, so, and a new focus. Whether we know a lot or not. But I think, you know, we've got a lot of data now.
Right.
We can at least see what the data look like.
Mhm.
And try to figure out how to interpret it. So there, I mean, of course, there's COVID, and there's going to be more COVID for the next couple of years, at least in terms of data, that we could also harvest from a bunch of countries, as well as general health outcomes, mental health. So I think there's lots of ways to go.
So
All right.
I don't know if we should follow up with some kind of survey, just get a sense of, you know, what people's appetite is for periodicity of these around, you know, or appetite for different topics. But
yeah, we've been feeling people were over zoomed until you know, recently we haven't wanted to do a lot extra, but maybe as time, maybe we could do a couple of these a year. That might be enough to integrate people on specific topics, and then people could come when they're interested.
Good. Well, it is 12:30 Pacific time, so thank you all. That this has been really enjoyable for me. I learned a lot from these, and so I look forward to the next ones.
And it's nice to see everybody.
Absolutely.
Great to see you, everyone.
Thank you again.
Great.
Thanks for all your,
Thank you.
thank you.
And thank you, Chunky, for arranging.
Yes, thank you, Chunky.